Eric Chaconis here, E1, Advanced Orthopedics, University of St. Augustine. Going to go over the oral practical exam, give you an idea of how it works, how we test you, and hopefully give you some pointers as you prepare. So I think that the more you're aware of the situation, the more you're aware of how we test you, maybe the less test anxiety you'll have going into it. So that's the goal of this. First of all, the criteria sheet can be downloaded from the course portal, and it's 2 pages, so you think of it as like 2 practicals, 2 separate practicals. The first practical is where you do a case, where you're going to do a history, you're going to do an exam on a patient, you're going to come up with a diagnosis, you're going to talk about treatment options. And then the second component of it is the technique part of it. So you're just going to simply pull a card, do a joint manipulation, and you're graded on that. That's out of 20 points. And the first one, the main practical, is out of 65 points. So it's really 2 separate practicals. That's kind of the way we grade it. So it starts where you will show up 30 minutes prior to your exam time. You will go to the designated location. You will bring whatever you want to bring with you. You want to bring your textbooks, notes, course manual, the lab manual, the seminar manual. I would definitely recommend bringing an anatomy book. You could bring McGee for your tests and measures, your biomechanics notes, whatever you want, because you're going to be given a case. And so this is meant to sort of simulate you're on your internship. The secretary says, hey, later on this afternoon, you got a patient coming in. They said that they had a fall last week. They've got some foot pain, and they're having a little bit of trouble walking around. And then the patient comes in, and you get their functional score, so lower extremity functional scale, 24 out of 80, and that just tells you, all right, this person's pretty low-level functioning. They probably aren't able to do a whole lot. They're pretty, maybe they're pretty acute, and their functional level is significantly impaired. The goal of this is, I think in your mind, check out the region, right? So I know they've got foot pain, and that's why, like I said earlier, at least bring an anatomy book. I know I'm gonna be examining this person's more than likely foot, ankle, somewhere in that region. Review the anatomy from that area, because what I notice quite often is students will forget a lot of the basic anatomy. So where does the posterior tibialis tendon attach? Where does peroneus longus and brevis attach? Where's the innervation for peroneus longus and brevis? That type of stuff. If you can review the anatomy right beforehand, review the biomechanics right beforehand, it really will help you answer some of those questions. The other thing is, don't get biased. I read this, and the first thing comes to mind is they're having trouble with weight bearing. They had a traumatic incident a week ago. Maybe they have a fracture, right? So I'm already starting to think in my mind, maybe they have a fracture. That's a mistake. You want it to be in the back of your mind. You want to consider it, but do not get biased. So we call this area this is like the holding tank, but sometimes people refer to it as the bias tank. You sit there, you're thinking about your case, you're reading this information on the paper, and you're developing hypotheses in your mind already off the bat. That's a huge mistake. Just look at the case, say to yourself, I'm going to be examining the foot ankle, let me review the anatomy, let me review the biomechanics, let me review the tests and measures, let me review the joint mobs, all the stuff that I might do on this patient, and that's it. That's it. Come in with an open mind. The other thing is, anything that's on this case needs to be verified by you. So just because it says 1 week ago they had a fall, I can't assume that that is accurate. I got to ask the patient. I have to verify. So I understand here that you fell down a week ago at Starbucks. Is that true? Can you elaborate a little more? Tell me a little bit more about the accident, right? So I got to ask them questions about that. So you can write down whatever you want, make whatever notes you want as you're thinking about the case and reviewing your resources. But when you come into the practical, you come in with nothing but a blank sheet of paper. So you're going to leave all your books in that room. We'll have teaching assistants in that room watching your stuff for you, so you don't have to worry about that. But you'll come into the practical with nothing but your lab coat, a wedge, a blank piece of paper, your case, right? That same sheet of paper we gave you the case on, a clipboard, and a pen. And that's it. So you're doing this history from a blank sheet of paper. And that really, really trains you to do a good history. And that's one of the primary goals of this exercise, is to really get you good at taking a history. So you will ask the instructor. The instructor is going to be the patient. They're going to play the patient. You're going to ask them questions pertaining to their situation, trying to figure out what's wrong with them, asking questions related to pain, function, medical type of questions. And so the instructor is going to be playing the patient. We often play patients that we've had in the past, so these are very real-life scenarios when we're answering these questions. And you're trying to figure out really what's wrong with them, develop some hypotheses as to what might be going on with them. So when you do it, you come in with a blank piece of paper, but first thing I would do when you introduce yourself, you say, "Hi, my name is Eric Chakotis. I'm a student physical therapist at the University of St. Augustine. I'm going to be examining your leg today, and I'm just going to ask you a few questions before we get started, if that's okay with you." And the first thing you do is you write down pain, medical, function. Just write that down. Because this kind of categorizes for me everything that I want to ask the patient. So I know I want to ask all the questions pertaining to pain. When did it start? Tell me a little bit more about the injury. Where's the location? Did it move anywhere? Did it spread anywhere? What's the nature of it? What does it feel like? What makes it worse? What makes it better? On a scale of 0 to 10, what is the pain right now? What is it at its worst? What is it at its best? How has it progressed over the last period of time, over the last few months? Has it gotten better, worse, or stayed the same? Do you have any swelling? Do you have any numbness or tingling? On and on and on, right? Every question you could possibly think of pertaining to their pain. Then from there you move on to medical. And you say, have you seen a physician for this problem? Have you had any diagnostic testing, any labs or imaging work done? You'll ask them questions about their medical history. Do you have a history of heart disease, diabetes, high cholesterol, high blood pressure, pulmonary dysfunction, skin dysfunction, gastrointestinal disease, and you go on and on. Full systems review, right? You want to get a solid understanding of their medical history. Do you take any medications? You get into red flag questions. Do you have any unrelenting night pain? Do you have any nausea, dizziness, headaches, fatigue? Do you have any loss of bowel and bladder control? Do you have any recent weight loss or weight gain? So all those red flag type of questions. And then you get that elaborate medical history, and then you get into function, right? What do you do for work? What are your hobbies and activities? Does this limit you in any way with any of that stuff? What are your goals? What's your living situation like? So you kind of get an understanding of their function. So that's just a little tip of how I would organize it. I think that's helpful. Some people will memorize like a mnemonic, and they'll run through every single possible question they could ask and memorize those. I think you do need to memorize questions, but I would categorize them. A good place to start is in the E1 manual and the seminar manual. You have on page 27 and 28 just some basic ideas of history questions. And this goes through some of the stuff I just talked about, but I think this is a good place to start. I think when you start to memorize your history, start with this. I think it's about 20 questions, and it covers everything from pain to functional type of stuff to medical type of stuff. It's not comprehensive, though. There's a lot more questions besides what's in there that you're going to need to ask. So other resources, the Maitland reading definitely is a great resource. We cover that usually the second or third day of class. And Maitland was such a good history. He was so good at taking a history. He could really hypothesize and figure out what was wrong with most patients after taking a history. And a lot of it wasn't so much the actual questions he asked, but the way that he asked them. So those skills, those strategies, such as paralleling, keywords, immediate response, right? we're testing you on that. We're testing you on your ability to parallel. We're testing you on your ability to use, to not be biased, not ask biased questions, and to use some of the strategies that he talks about, like immediate response and keywords and stuff like that. So I think that some areas to really highlight, this is important to recognize, paralleling is so imperative when you're asking the patient questions pertaining to their pain. So for instance, onset. If I say, tell me a little bit about when your pain started. And you say, patient says, well, over about a month ago, I started running and started feeling pain on the side of my knee. Okay? If all I do is accept that as the onset, I'm really missing out on a lot. I've got to parallel that information. So saying things like, well, I understand that the pain came on the side of your knee when you were running. Did you have a fall or an injury, or did it just come on gradually? Patient says, well, it came on gradually. All right. Did you do anything differently? Did you change the amount of mileage that you were running or anything like that? Yeah, I started ramping up my mileage. I started running, probably an extra 10 miles a week compared to what I was doing before. Okay. When you noticed it on the side of your knee, did it move anywhere else? Did it radiate anywhere? No, it just stayed on the side of my knee. All right, well, describe that pain a little bit to me. It feels like an ache, right? So you're just paralleling, you're digging deeper and deeper and deeper into the topic pertaining to the onset of symptoms and what it feels like. Another good one is location, a parallel location, really, really heavy. Because if they just say it's on the outside of my knee and they point to it, that might not be enough. You might want to ask, well, I understand it's on the outside of your knee. Does it feel like superficial or deep? Does it feel like you could touch it, or does it feel deep inside your knee? I understand it's on the side, but do you feel like it moves up or down at all, or to the back or to the front at all? So you get more info on location. What makes it worse is another good one. What makes it worse? So it's worse with running. All right, well, tell me a little bit more about that. Is it the further you run that the worse it gets, or is it right immediately when you start running? It's the further I run. Do you notice any difference with surfaces or shoe wear or anything like that? So you're just expanding on the information they're giving you. Another good resource, Guide to PT Practice, page 44. Figure 2 in the guide on page 44 gives you a full kind of types of data that may be generated with the patient-client history, and it kind of highlights that full systems review, and it really is a good comprehensive sort of picture of all the questions that you're going to want to ask. Other good resources, Mock Clinic notes. Mock Clinic is a co-requisite for E1, so you're either taking Mock Clinic while you're taking E1, or you've already taken Mock Clinic, and so you want to rely on some of those notes that you took in the types of questions that you want to ask for the history of Mock Clinic. It's a similar history to the Mock Clinic history. It's just that we expect you to use more paralleling, more detail. The quality of the history should be better, and as well as the fact that it's just on a blank sheet of paper, so you really have to have all this stuff off the top of your head. After you do the history, you're going to generate some hypotheses. So you'll do the full history, and then you'll say to the instructor, all right, I got a couple hypotheses. One of them is it could be a lateral meniscus tear. The other one is that it could be a lateral knee pain like ITB friction syndrome. And the other one is it could be a biceps femoris tendinopathy. And we'll say, all right, then why meniscus tear? So you need to be able to defend each hypothesis with specific data from the history. So you'd say, well, there was no trauma, but it seems like maybe a degenerative type of meniscus tear because the patient had pain. They're a little older, maybe they had pain over a long stretch of time. They began to experience some clicking, popping. They reported what seems to be maybe some knee joint effusion. It's on the joint line in the lateral knee area. Okay, great, that makes sense. Why biceps femoris tendinopathy? Well, the pain does occur with running, specific knee movements of active knee flexion they report to hurt, and it's really the location is pretty consistent with where the biceps tendon attaches, so you get the idea. You just got to be able to defend your hypothesis. You don't have to have a certain number of hypotheses. We're not looking for a magic number. We're looking for you to come up with the hypotheses that make the most sense based on the information that we gave you. Now, the information that we gave you is only as good as your history, right? The better your history, the more you're able to ask good questions with good strategies, good paralleling, the better you're able to pull information from us. So I think that the quality of your hypotheses is very much dependent upon the quality of your history. Now, that being said, the whole history needs to be done in about 12 minutes. So we want this to be a comprehensive and thorough history, but at the same time, you need to get it done efficiently and relatively quickly. And that's the reality of the clinic. You really don't have more than that much time in the clinic to do a good history on a patient when you're doing an exam. So it's a reasonable amount of time to get it done. Once you develop your hypotheses and we've talked about them, then you'll test them with your physical exam. So we'll say, all right, this is a wrist exam, but now we'll say, all right, we want you to delineate between those three hypotheses that you just described. And you'll say, all right, well, I'm going to do passive range of motion classical. I'm going to do passive range of motion accessory. I'm going to do an MSTT, and I'm going to do a special test. Very much recommended that you do the exam in the order of the 18 steps, right? So I'm going to do classical and accessory before MSTT. I'm going to do MSTT before special test because I don't want to get biased. I don't want it, the exam was designed in the order in which it's designed in for a reason, and you want to stick to that. It's going to make you more accurate. You're not doing the full 18 steps, so it's very important to recognize that. You're just going to pick the most pertinent exam steps to differentially diagnose this patient's condition. Now, you may do an extra step, such as like a movement analysis to get a better idea of their functional performance, the way they're able to do a functional movement. But for the most part, it's really just differentially diagnosed between the pathologies that you've described in your hypothesis. Now, when you do the physical exam, you'll actually be doing it on another classmate. So the other classmate will be in lab clothes. They'll lay down on the table. You'll do the tests and measures on them. And the examiner, the instructor, will be giving you the data that you're asking for as you're doing the physical exam. So then you'll come up with your diagnoses, and you'll say, all right, I believe it to be a biceps femoris tendinopathy. I believe it to be in the acute stage of condition. I believe it to be more of a reactive tendinopathy. So there's some fluid in the area, right, with a relatively acute onset. The tissue activity is moderate because my muscle length test showed pain at the resistance of the hamstring muscle length test. It is a high subject reactivity because the patient's unable to do any of their activities, and that's all the information that we're going to need there. Then we'll talk about the interventions and the management. So then you'll say, all right, for treatment, what I want to do today is I'm going to educate the patient on running surfaces and shoe wear. I'm going to educate them on the Price principle. I'm going to teach them how to wrap their knee, how to ice their knee. And I'm going to go over kind of what we're going to do in rehab. And then we'll say, all right, good. Now it's visit number 5. They're getting better. The fluid is gone from the tendon. They're experiencing a significant reduction in symptoms. Now what do you want to do? You'd say, well, now I'm going to assess the kinetic chain. I'm going to look at the hip. I'm going to look for any compensatory movements like a knee valgus or varus position. I'm going to look at the rear foot, looking at the kinetic chain there and trying to see if that's involved at all. I'm going to address these impairments by strengthening the weak muscles, and on and on. And that's a very customized sort of conversation we're going to have. I mean, that conversation we have about treatment is going to vary a lot depending on what went on during the case. But it's just an opportunity for you to describe your knowledge of rehabilitation and how you'd progress a patient in this specific case. So then that portion of the practical is over, right? We're grading you on the interview, the physical exam, the evaluation, diagnosis, tissue activity, all that stuff, intervention and management. Sometimes we'll ask you to do one of the interventions. You'll say, all right, I'm going to do, now it's visit number 13, and they're getting a lot better. They're getting back to running. I want to do some eccentric loading of the tendon just to induce that final stage of healing and to make sure I can prevent future problems in the biceps femoris tendon. And so we'll say, all right, good. Show me the exercise that you want to have them do. Teach the patient the exercise. So you'll teach the patient how to do it. This is where we grade you on the oral. So we use these criteria here. We're asking you questions. It's a 4-point scale actually, because you can get 0 points if you're below 70. But this 0 to 3, how many points based on each question we ask you? Now the total oral component is about 12 points of the exam. There's a little bit of overlap though, because like sometimes, the hypothesis, do you state a correct hypothesis or not based on the information you had? There's 6 points there, but also we may ask you a handful of questions pertaining to the hypothesis. So you may get, some of the oral exam component kind of plugged into your hypothesis section. Then the technique practical. It's really just like your ortho technique only practical, where you're just doing a joint manipulation. We will ask you to select a card. The card has a technique on it. You'll go ahead and perform the technique. We'll grade you on it, and then it's done. So that's the practical. You need at least 16 out of 20 points to pass the technique only. You need at least 52 out of 65 points to pass the exam, history and exam section of it. We give you feedback after it's done. We'll go over the practical experience. We'll kind of talk to you a little bit about what you thought about the experience, and we'll give you a lot of constructive criticism, as well as compliments. I mean, if you're doing something good, especially if it's done exceptionally well, we'll tell you about it. It's really important, I think, to have a good attitude when you're getting feedback, and we notice this a lot where people will get upset. And there's no reason for you to get upset. There's no reason for you to get emotional. Nobody's perfect, right? Nobody can do an incredibly awesome physical exam and history and all that stuff at this point. You're literally, a year and a half into PT school. We don't expect you to be a master clinician, but the only way we're going to get you to the level that you need to be is by critiquing you, giving you feedback, correcting your mistakes. It's our job to do that. It's our job to get you better. You don't want us to be overly nice and all sugarcoating everything. You're never going to get better that way. Nobody's going to improve. So have a good attitude. Take the feedback. Take it seriously. Consider it. And use it to improve next time. Like I said, we do that because we want to see you be successful. And the only way you're going to be successful is if we criticize the mistakes and highlight them so that you can correct them. All right? So hopefully that's helpful, and we'll talk about this a little bit in class before the practical. Usually about a week before the practical, we'll answer any questions that you have, but feel free anyway along the way in the semester, email us questions about the experience, and we can certainly help you out in any way that we can. So thanks for listening. I hope that was helpful.